this up, and that is really funny. All right. So we're going to let everybody populate here in the room because we're at start time and we have a hard stop at 6:59 p.m. because we have other people that have to go to other places to do other things. So we are going to, okay, we're streaming well on Facebook. We are streaming here and we've got 9 of you, 10 of you. If you are in the Zoom room, please complete the first poll. There will be a second poll during this session. And just to confirm that we wrote this the right way, based on what I have learned in this webinar, before this webinar, I feel clear and comfortable with my understandings of what level of activity is right for me. That's the question we're starting everybody with. We're going to hope that we're going to move the needle a little bit on this question. And the second question we're looking at is, I am clear on the difference between exercise, recreational sports, and competitive athletics. And there's some areas that people aren't clear on yet that we're learning about. So you'll have some time if you are entering the room. Stacy, maybe you can remind people in chat in the next couple of minutes to take the survey as the rest of them come in. We've got 25 attendees. We're expecting 100 this evening. The numbers are growing and we're going to get started in just another minute or so with our presentation. I'm going to pop up my screen over here and we will show our slides. Okay, so we're still going with the poll. Don't get distracted. Finish the poll. We want to know how we're doing. So welcome everybody to this special edition webinar from the Hypertrophic Cardiomyopathy Association. And we are going to be talking about the LIVE HCM trial. Thank you all to those who participated as participants in the trial itself, as well as our investigators. The published JAMA article came out on May 17th. I was out of country at the time, so we couldn't do it any sooner, but the data is still accurate a few days later. So we're joined by Dr. Rachel Lamper and Dr. Charlene Day. Dr. Lamper is coming to us from Yale, and Charlene is coming to us from Penn Med or University of Pennsylvania. And we are going to be going over the study design, a little bit about what we were looking at in the LIVE HCM trial itself. And we're going to start off with Dr. Day going over some of the background of the trial. We're also going to hear from Cheryl Barth, who many of you have spoken to. If you were in the LIVE HCM trial, she got to do all of the coordination and get you all organized in here. So she's done a lot of work on this trial, and we're happy to have her with us tonight. We're going to learn a little bit about the study results from Dr. Lamper, and then we're going to talk about some future options that you have for helping yourself figure out what level of exercise is right for you. So without further ado, I am going to move to the first slide and welcome Dr. Day. And Charlene, this is all yours.
Great, thank you so much, Lisa. So I'm going to start us off and provide some background to the LIVE HCM study. So I think everyone knows that generally speaking, it's well established that exercise has many physical and mental health benefits for everyone. But for patients with HCM, there's been a long-standing uncertainty about whether any level of exercise could be too much. So in other words, could exercise put too much stress on your heart if you have HCM? Could it trigger potentially life-threatening arrhythmia? And we really haven't known the answers to these questions. And it's not surprising that you all have a lot of questions about exercise, and we haven't always been able to answer them. So you wanted to know, is it good for me to exercise? Is it safe for me to exercise? How much exercise can I do? How much should I do? And then what about high intensity exercise or sports participation for those who are so inclined? You can go to the next slide. So a little over 10 years ago, Lisa and I were just reminiscing about how we started to put a survey together to gather information about exercise practices in patients with HCM. So we put this survey out to patients at the University of Michigan, where I was at the time, and also through the HCMA, asking about how much exercise people were doing, whether they were restricting their exercise purposefully, et cetera. And so the main conclusions from the survey were that patients with HCM exercise less than those in the general population, that more patients with HCM were overweight or obese, and about 2/3 purposely reduced their exercise after they were diagnosed with HCM. And for the majority of people who reduced their exercise, this had a negative emotional impact on them. And then we found that only about 45% of HCM patients were meeting the recommended guidelines of 150 minutes of moderate or vigorous activity per week. And that graph on the right is from another study that came out from the group in Australia several years later, looking at how many minutes of moderate intensity or moderate or vigorous physical activity patients were doing per week. And as you can see, the largest bar are those in less than 30 minutes a week. You can go to the next slide. So then, having identified the extent of the problem, we then set out to perform an exercise intervention in patients with HCM. This was a collaboration between the University of Michigan and Stanford, and we randomized 136 patients to either their usual activity, where they received no specific exercise guidance, or to an exercise training program. This was a moderate intensity exercise program where most patients were walking, using an elliptical, or riding a stationary bike. And it was individualized for each person, but in general, we started kind of slow and light, depending on how much exercise someone was doing at baseline, and then progressed over the course of 4 weeks. They sort of built up their exercise program and then maintained wherever they were at the end of 4 weeks until the end of 16 weeks. And compared to the patients in the usual activity group, you can click the next slide. Thank you. Compared to the patient's usual activity group, those in the exercise training group experienced a significant improvement in their exercise capacity when we measured this with a number called the peak VO2, or peak exercise capacity. Many of you may have had a cardiopulmonary exercise test and might even know what your peak VO2 is. But we saw an increase of about 6% on average, which is a pretty substantial amount for a 4-month exercise training program. So those in the exercise group did better on their stress test, and they also felt better. And so when we surveyed them using a standardized functional assessment survey, there was a significant jump in their functional capacity compared to those in the usual activity arm. And importantly, there was no increase in arrhythmias with exercise training. So this study provided us with a lot of reassurance around moderate intensity exercise for patients with HCM, but really didn't address vigorous intensity recreational exercise or participation in competitive sports. And so this was the purpose and the motivation for the Live HCM study that you're going to hear about now.
Okay, I'm going to pause for a quick second before we hand over the microphone to Cheryl, and we're going to talk about this poll that we put out. So I'm going to ask everybody, if you haven't done it, do it really, really quick. You have like 2 seconds, and then I'm going to launch the survey just to show us where we are. We have 85% participation right now. If you haven't done it, 3, 2, 1. I'm ending the poll. And I'm going to share the results with you all immediately. So we have a pretty good array of the US here: Northeast, Southeast, Midwest, West, Canadians, no Europeans, but we have an Australian and a Canadian. Welcome to the crew. Actually, we have several. Nope, that was West. Okay. What is your relationship to HCM? So 62% are patients, 21% are patients with a family member also with HCM, 1 family member alone. We have 6% of you are medical providers, and 9% work for industry. We don't have any just curiouses this time. And here's the interesting questions. Based on what you've learned before this webinar, I feel clear and comfortable with my understanding of what level of activity is right for me. 29% say they completely agree. 41% say they somewhat agree. 21% are neutral. 3% disagree. And 6% really disagree and are confused. So we're hoping at least we can move the mark on those really confused people and get them more not confused. And I'm clear on the difference between exercise, rec sport, and competitive sports. 44% agree, 41% somewhat agree, 6% are neutral, 6% disagree, and 1 really disagrees and is completely confused. So let's hope that we can move the mark on these individuals who are confused or add some clarity to their understanding. And now I hand the microphone to Cheryl.
Thank you, Lisa. You could go to the next slide.
Sorry, there you go.
Okay, so with the Live HCM study, the question we're trying to answer is, will individuals with HCM who are exercising vigorously have a higher rate of arrhythmia-related events than those not exercising vigorously? Keep going, next. So who is enrolled in the study? People with HCM or had the gene for HCM and a family member who has it. Our participant ages range from 8 to 60 years old with or without an ICD. They were enrolled in the study through participating sites, or they were self-enrolled, meaning they heard about the study either through the HCMA or another organization and contacted our team directly. Next. So any level of exercise was welcome in the study, whether you like to run, walk, or sit and read a book. We included people who had a relaxed lifestyle, as well as those who were more active. Next. So at the start of the study, once we connected with the participant, we had them fill out a medical history survey, an activity survey, and for the self-enrolled participants, we had them complete a medical record release so we can request records. So for the activity survey, we asked them what activities they were doing regularly, when they were doing these activities, whether it was within the last year or earlier in life, how long they did the activities, and whether they were done at a recreational level or a competitive level. Okay, next. We would check in with the participants every 6 months. When they completed their medical history update survey, and if they checked off a cardiac event, we would reach out to their physician and request records to document that event. Okay.
All right, thank you,
Okay,
Cheryl. So
Cheryl.
that was what the participants did. And we started enrolling in 2015. We completed in 2019 with enrollment. And so by the end of 2022, everyone had 3 years of follow-up. And these are the results that came out this May. Just a couple weeks ago, we presented the results at the American College of Cardiology in March, and then the paper came out in May. So overall, 1,660 individuals enrolled and had at least one follow-up. 996 were men or boys, 664 were women or girls, 122 were less than 18 years old, 149 18 to 25, and 1,289 were 26 to 60 years old. 92% had frank hypertrophic cardiomyopathy. So 8% had a gene for HCM, but didn't actually show it in their heart. When we looked at their activity levels, we found that 440 were participating in vigorous activities in recreational or non-competitive ways. 259 were doing vigorous activities in competitive ways. 709 were doing moderate activities, and 259 were less active. For the purpose of analysis, we grouped together the vigorous, for the primary analysis, we grouped together the vigorous competitive and the vigorous non-competitive into the vigorous, and the moderate and less active into the non-vigorous. Next slide. So our endpoint that we were looking to see how people did was what we call a composite, meaning it included several different endpoints, which included death, cardiac arrest, syncope, which was, or passing out that was felt likely due to an arrhythmia. We had a committee that went through the records to determine if they thought it was arrhythmic or not. And then for the patients that had an ICD, if they had an ICD shock for ventricular arrhythmias, and again, we had our events committee take a look at the ICD printouts. So what we found was that there was no difference between the vigorous and the non-vigorous participants. Those who were not doing vigorous activities, 4.6% of them had one of the events. And for those doing vigorous activities, 4.7% had one of those events. And there was no difference between these two numbers. As you can see, they're pretty much identical. This graph looks at time and how many people at each time point were free of that event. And as you can see, the lines are pretty much superimposed between the vigorous exercisers in red and the non-vigorous exercisers in blue. I'll just say a couple other words about a couple of particular subgroups. We looked at the 92% who had overt hypertrophic cardiomyopathy, and the results were similar. We looked at those who were competitive, and again, the results were similar. We had a very small group of varsity type athletes, young people in high school and college who were participating in interscholastic varsity type sports. There were 42 of those. And we compared them to individuals of similar age. That group is obviously too small to be making statistical comparisons, but from just looking at the numbers, there was no difference there either. So in summary, in this prospective study of 1,660 individuals with hypertrophic cardiomyopathy or who had the gene in the 8%, those who were engaged in vigorous exercise did not experience a heightened risk of death, arrest, appropriate ICD shock, or arrhythmic syncope compared to the individuals who are engaging in low to moderate intensity physical activity. The individuals who were participating in high intensity competitive sports were also not at heightened risk. And again, when we limited the analysis to those who had overt hypertrophic cardiomyopathy, the findings were similar. And the overall event rates were low in both the groups, with less than 5% having any arrhythmic events over 3 years. Next slide, please. So these data don't support what has been a universal restriction of vigorous exercise in patients with hypertrophic cardiomyopathy. But rather, they should inform discussions between patients and physicians regarding vigorous exercise participation in the context of expert assessment and management of hypertrophic cardiomyopathy using individualized, shared decision-making types of discussions. And one thing that we really do want to emphasize, again, is that although many of our patients were self-enrolled and came to us through the HCMA or hearing about us in other ways, the large majority of them were followed in expert HCM centers. And so having that discussion with an expert provider is really critical. So we'll move on to Dr. Day. Back to Dr. Day.
Back to Dr. Day. I'm going to launch the second poll in just a few minutes, if I can figure out how to do that. So you may see another poll come up. It's a different one, so you can take a look at that. But I've never done that second poll before. So, oops, I'm going to close the first poll and I think I'm going to go to the second poll. There we go. I'm going to launch a second poll, but I'm going to ask you to give it a second before you answer it because there's going to be a little bit more data. So Dr. Day, back to you.
So did you want me to wait for the poll to be completed?
Nope, we're going to do that at the very, very end because we
okay.
have to answer some more questions for them, but now they have a secondary poll that they can start answering.
Okay, great. So to try and answer some of the questions that that you have all posed to us, these are responses that we have now, and I think with Live HCM we have a lot more certainty. So is it good for me to exercise? I think emphatically we can say yes, it's good for you to exercise. Is it safe for me to exercise? I would say generally yes, although I typically don't like to use the word safe because I don't, it's hard to define what safe means. Safe does not mean zero risk, but nothing you do in your life is zero risk. And so the question is there a difference in your risk if you exercise versus not? And I think the data so far support that there is no difference in risk, right? But it's important that you discuss with your HCM physician and team because there may be specifics around your situation, or there may be certain timing, like if you, for example, if you're somebody who you've decided with your physician and your medical team that you should have a defibrillator implanted, it may be reasonable to wait a period of time, for example, until that's done. So that's just one example where I think the timing is important and individualized decision-making is key. How much exercise can or should I do? Well, in general, we use a guideline of 150 to 300 minutes per week of moderate intensity exercise as a good goal. That's what has been shown in the general population to achieve long-term benefits for your heart and longevity. But some people want to do more than that. Either they want to do more in terms of duration or they want to do a higher intensity. And so that's really what the Live HCM study addressed, was for those who are capable of and are interested in doing higher intensity exercise or participating in sports. the Live HCM study suggests that those individuals are not at an increased risk of having arrhythmic events. But again, as Dr. Lampert said at the end, it's important to talk to your HCM provider to tailor a program that's right for you.
Okay, so I'm going to pause here and I'm going to stop my screen share for a minute. We've got some other slides we're going to show you in a few minutes, but I want to get into a little bit of a discussion here as we get this poll going. And if you have a particular question, please use the Q&A box, not the chat box. And we're going to spend a good 20 minutes going into your questions. So we're going to get to them all. Now would be the time to post your questions. So to both Dr. Lampert and Dr. Day, we know for a long time prior to the start of this study that some patients were participating in sports and athletic activities, and maybe they weren't telling their doctors everything that they were doing because they were told no, 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 but they were doing it anyway. So part of the interest in doing this study was to say, okay, we know you're doing it. Let's see how safe you all really are and what we can learn from this experience. And it wasn't without controversy getting to this point, and it wasn't without some really deep conversations about how to set this up. And it has been quite an interesting decade getting to this point. I will just put that out there. But here we are now with some data. It would be nice to have even more data to look at, but this is what we have to look at. And I want to be clear with the people who are viewing, and we've already had one question of what if there's not a center by me? How do I help get this assessment? Exercise has been deemed by just about everybody in the HCM space as something patients should do. And I think we've educated people, hopefully, with this study and the work that you guys have been doing along with a lot of our colleagues to explain to people that it's safe to exercise with HCM. And in fact, it's probably detrimental if you're too sedentary. We know that those of you who are heading to transplant may have a hard time exercising, but at least physically walking around has been viewed to be beneficial. But for everybody else, exercise is really important. Can you guys both just talk about the value of exercise and how exercise is defined? Rachel, you're off of mute, so you get to go first, followed by Charlene.
Actually, you know what? I think for this one, Charlene, why don't you start because I think it kind of really, reset really addresses a lot of that piece of the question.
So, I mean, do you mean, Lisa, are you talking about the distinction between recreational, different intensities, or just
the definition of what is exercise? Is walking, is going on an elliptical, is going to a gym, is it like, what is exercise?
Right.
How do we define
So it doesn't have to be, I mean, it doesn't have to be structured. Although I generally encourage people to set aside some time in their day to do something for an extended period of time, 20 to 30 minutes, ideally, to really get the maximum benefit. But you can work in a lot of exercise into your daily life. So for example, people that commute on a train or a bus and then walk from the train station to work, that's exercise, right? So walking is definitely exercise. And that's really all you really need to do to get the benefit for your heart, for longevity, right? So people that do 150 to 300 minutes of moderate intensity exercise a week reduce their overall mortality, or they live longer. That's the bottom line. And they generally feel better. They're fitter and they have fewer, risk factors that are gonna, for coronary artery disease. So this is just in the general population. So that's what we use as a good guideline for people with HCM, because there's no reason to think that that threshold would be any different in someone with HCM. Now, there may be unique benefits to exercise for somebody with HCM. So the HCM heart may benefit directly from the effects of exercise. But, for the maximum benefit, I think you're going to get the most out of moderate intensity exercise. The question becomes, for vigorous exercise, that's a choice, right? And yes, you get
So
better.
let's step up to vigorous. So exercise is walking, doing some stretching, yoga, maybe an elliptical or piece of equipment to do some toning, etc. That's exercise.
Right.
Can you define recreational athletics?
Yeah. Well, I should just preface that the last statement you made about, whether it's toning or stretching. I mean, generally we think of it as aerobic exercise. So that 150, 300 minutes is not just stretching, but getting your heart rate up a little bit and, working in your aerobic zone. Now, supplementing that with some strength training and stretching, and that's all good too, but those number of minutes, that recommendation is really based on aerobic exercise.
Thank you for the clarification.
So then the distinction between recreational competitive is really more of a mindset, I think, than anything else. There are people who exercise vigorously who really enjoy and thrive on the higher intensity, and they like to really be out of breath, and they like to do interval training. They just enjoy it. And so that's for the purpose of their fitness. And if they're able to do it and they enjoy it, then that's really the group here that we were trying to address. But if they're not competing against, in a formal, organized sport or race, then that would be considered recreational. People who are competitive are really doing systematic training for the purpose of performance. And there is a fine line there, and there's obviously a lot of overlap, right? So there's people who are on the Peloton leaderboard, competing against other people who they don't know, right? But they want to get their place on the leaderboard and are going to push that extra, few watts to get there. I mean, that's a mindset that to me is sort of competitive, right? Even though they're not in a formal organized sport. I mean, for the purpose of this study, those people would still be defined as recreational because they're not directly competing against somebody else. But again, there's definitely overlap and a gray zone.
And then when we get into the competitive line, there's different levels of competitive activity. So whether you're in a JV league as an adolescent, a high school or college team as a young adult, or a competitive professional team, these are very different levels. Do you look at them differently in this trial?
We're doing some sub-analyses, and as Dr. Lambert pointed out, we've already done the subgroup analysis of the 42 individuals with HCM who were doing competitive sports at the high school and collegiate level. I fundamentally don't look at them really any differently, except that the level of systematic training that a professional athlete or collegiate athlete is going to do is very different from somebody who is a master's athlete who's training for a 5K. So the level of training that somebody's doing, both in terms of the volume and intensity, is quite different. I'm not sure that necessarily their risk, if there is an excess risk, would be any different.
So of the intense competitive athletic participation in the trial, could one of you define what levels these people were participating at?
I'll let
For
Dr.
these 42, these were the highest level athletes. They defined themselves as interscholastic, varsity. I think one or two we were JV, but for the most part, these were varsity. People who had told us they were participating in interscholastic varsity sports at the high school and college level. And again, these were the vigorous sports. So we didn't look at, competitive golfers and that, that group. These were really people whose sports, put them in the vigorous category. And then we're doing those sports interscholastically in the high school or college level. We didn't have professional athletes in this study, but we did have, high level college interscholastic athletes.
So there are some critiques that this is a self-selected population. They chose to be in the study. Somebody had previously died from a cardiac arrest, they would not be a candidate for the study. So
I would love to address that. That is such a great question, because self-selection is so important in any observational study, but particularly one like this about exercise. So we address that question, which is it's so important in a couple of different ways, because of course, the sickest people are potentially at the highest risk of an arrhythmic endpoint. And if they're not exercising, then you're absolutely right, that could bias the results. So we address that a couple of different ways. First of all, we didn't enroll class 3 and class 4, which is a way of looking at the sickest individuals, people that really are short of breath no matter what they do. So we didn't enroll individuals that were, that sick at all. We did enroll people that we call class 1 who are completely asymptomatic. And then we enrolled what we call class 2 heart failure, which means that sometimes they're symptomatic and sometimes they're not. If they do a lot, they might be symptomatic on some days, other days they might not be symptomatic. So we did enroll both of those, that sort of level of symptoms. We did look, though, at the group that was completely asymptomatic separately. So the people that said, I'm never short of breath, I always feel fine. We did look at them separately, and we also found that even just limiting the analysis to those completely asymptomatic people, that we didn't see a difference between those who chose to exercise and those who didn't. So while self-selection is so important, I think we were able to control for that or account for it in our results. I think there's another interesting thought, though, about how symptoms and exercise interact. We know from the reset study that Charlene talked about earlier, that people who go into an exercise program with HCM feel better. So some of the people, we don't really know if you're symptomatic and you're not exercising, which is the chicken and which is the egg. But I think I think for those people now getting into some moderate exercise, we know is going to be safe and likely make them feel better. But I think even sort of aside from that way of thinking about it, when you just take those people out altogether and we just looked at the truly asymptomatic that could do as much as they wanted, we did again see that the exercisers did not have higher risk than the less active people. So I think that's a really important thing to be thinking about.
If I might add something to that too, the other thing that we did was we used some statistical methods to control for sudden cardiac death risk factors. Because our primary endpoint was arrhythmic events, and so we wanted to put everybody on par in terms of what their estimated risk would be based on established risk factors. And when we did that, there was no change in the outcome. And so the groups were actually well matched, right, between the vigorous and non-vigorous in terms of their sudden death risk factors. They were well matched at baseline, but even when we adjusted, there was no difference.
Also, just to address something that was said earlier, we did actually have people who had survived cardiac arrest that were exercisers. Most of the time, or pretty much really any of the time, people that have a cardiac arrest are going to end up with a defibrillator. And we had a lot of defibrillator patients in the study. We had active defibrillator patients, less active defibrillator patients. We've done a prior study looking at athletes with defibrillators, including a number with HCM, that found that those people are okay doing vigorous exercise as well, that the defibrillators work, even during sports. So it was not a low risk population. It was people that have real HCM. Many had defibrillators, but the vigorous exercisers did okay.
Just to give them an idea of how sick some of these people were, you had quite a few people go off to transplant during this time as well.
Yeah, we did have some people that ended up getting transplanted, although something we've talked about in the past, Lisa, it was interesting because many of them were class 2 or, not highly symptomatic at the beginning. They were sort of up and down, and then they ended up getting transplanted. And I think it tells us something about sort of the variability of symptoms and how hard it is to predict the course sometimes.
I would say going into this, and there's a couple questions coming up, but we're going to pitch back to Dr. Day showing us some other data in just a second. We only have 2 or 3 more slides, and then we're going to get to all of your questions. It was a hard question to ask. We've never asked the question in a formal way about who should participate in what level of athletics and recreational athletics and competitive athletics. We've never gone there before as a community, in part because, sudden death in athletes, big headlines, scary topic, and let's not go there. But we went there and we found that there's no statistical difference between these groups after expert review of the individual anatomy, risk factors, and good management. I think if there's any big note here, it's expert management really is important. And it's making a difference in how we can live with our disease state. And I'm really excited about that. There's just so much happening now that's putting a little bit of control back to the patient with the clinician in a way that is showing that it can be safe. Now, I'm going to bring up one other point, and then we're going to go back to the slides. The importance of good management. And the person, I believe, is on the call listening that this happened with. I have somebody who was training for a big event, hadn't checked in with their center in quite a while, didn't have any additional testing done when they finally did check back in, just a quick, how you doing? And 2 weeks later had a cardiac arrest because we found out afterwards that they had developed an apical aneurysm, which we know is a high risk for arrhythmic event. So the message here is, no matter whether you're trying to do a competitive event or you want to exercise, checking in with your center and making sure your care is optimized is critically important to success and longevity in living with HCM. Doctors, please comment.
You know, one thing I'd like to comment about that too is that our data don't show that people with HCM have no risk. What our data show is that the risk isn't different between the vigorous exercisers and the non-vigorous exercisers. So it really emphasizes the importance of ongoing assessment, as Lisa's talking about, because risk changes over time. Whether you're exercising or not, you can develop the markers that tell us that maybe you are at risk, maybe it is time to consider a defibrillator. And so really thinking about risk assessment, it's not sort of a one-time thing that you do once in your life. It's really an ongoing relationship with your physician. Again, aside from sports or no sports, an ongoing relationship with your physician that's going to constantly be re-examining your risk.
Charlene?
I don't have much to add to that. Yeah,
Yes.
I totally agree. Yes.
Yes.
It's,
Okay,
it's so important. You need to, continue to follow up because things change. And your risk may change regardless of whether you're exercising or not. So it has nothing to do with being an athlete. Just because you're an athlete doesn't mean you should check in more frequently. It's the same, right? Same recommendations for everyone.
Surveillance is equal regardless of your level of participation in competitive athletics. It's just important because HCM changes over time. Okay, Shar, if somebody wants to do something to try to make themselves comfortable in exercising, our friends at ACC have created some really great tools.
Yes, so I think, Lisa, you were involved in this, the cardiosmart.org. There were a number of us who helped to put this together and worked with the ACC. And this is part of a larger program. So I encourage you to visit cardiosmart.org HCM. There's a lot of great information in there. It's all up to date. We're trying to replace a lot of the misconceptions that are out there on the internet. So this is the place to go for updated information. And I'm just going to highlight the HCM exercise planning worksheet, which is part of, this was a big chunk of what we worked on here. And so the idea is that you can use this worksheet interactively, work with your health care team to get a true picture of your current exercise habits, what you're able to do now, what your goals are, right? So goal setting is really important. And then what are the barriers? Because some people just have a hard time exercising, not because they have HCM, just because, like a lot of people have, busy lives and it's a lot going on. It's hard to find the time and the motivation. But this is a way to help to set goals and to achieve them. So here's just an example there of the weekly HCM exercise planner that you can use. And so you can print it out, or I don't know if you can get this planner on your phone, but I'm sure there's an app that you can track your progress. Yeah, so I just really encourage you to visit the website and take a look and see if this would help you to establish a new exercise program or to change the direction of the exercise you're already doing.
Okay, we're going to go back to the questions now, because you got 17, 18 of them out here, and Rachel has a hard stop in 40 or in like 20 minutes. So we're going to go fast here. And then I'm going to get you, after we do a couple questions, I'll show you how we're doing on the poll. Okay. How much do you think self-selection occurred, whereby being symptomatic? I think we answered that question, Justin. Symptomatic, non-symptomatic, vigorous exercisers, and sedentary were all recruited for the trial. I don't think we have any other question there. So I think we've answered that. Next question. Done. If you live somewhere with no HCM specialty centers and patchy expertise, what is your advice for these individuals? Would you still advise exercise limits to those individuals? This is a tricky question. It's a really tricky, but very
Yeah.
good question.
Yeah, I mean, obviously the answer is that we need more HCM centers, right, Lisa?
I'm working on it. I got 2 more
Every
coming and
state,
5 more on the path, so we're getting there.
But I think that, no, I don't think that you should limit your exercise. I mean, I think certainly if you want to do a moderate intensity exercise program, it's completely in keeping with the guidelines. I don't think that that you should purposely limit your exercise because you don't have an expert HCM provider and HCM center. I think that where the threshold is for competitive athletes, that's where I would probably recommend that you seek expert provider advice, just because of the nuances. And there's not every athlete is well represented in the Live HCM study or in any other published study, right? There are others out there as well, but we can't possibly represent every type of athlete, every type of individual. So I think there's enough nuance that for a truly competitive athlete, I would ask Lisa who you should talk to. But I think for most recreational exercise, as long as you're happy with your care and your follow-up, and you encourage your provider to read the literature to be up to date, then I don't think you should change your exercise practices.
And I will tell you, I'm trying to put together a big project, and it's not just, it's for international, but it could be used for US citizens as well. I want to figure out a way to set up a virtual HCM clinic that all of our experts can participate in, and it would probably end up being a little volunteer time to the docs, but it might have to work that way so that we can do assessments. You can get your clinical evaluations done locally and then have that opportunity to meet with an expert in a virtual international clinic.
Yeah.
Where we can get different people to get involved. So we're doing a little fundraising for that right now. So stay tuned for more information as we develop that out, because we know that there's a problem and that there's a lack of coverage throughout the world. It's not just US.
Yeah.
So
I mean, I've done this for some, particularly during COVID, when we could do televisits and we could get emergency licenses in 24 hours. But even now, I've still done some. And different states have different arrangements, and sometimes, so you could check and find out what your state would allow you to do. For example, Arizona allowed me to collaborate with the physician, so we just had a televisit with that collaborating physician on the call, and then they were able to reimburse us and all that. So
that's always the tricky part, but I think I might have ways around that. So we'll talk more about that soon. So Adam has made a statement that is not based in fact. I'm sure Lisa is sick of me being the resident skeptic on the Facebook group. No, Adam, I love skeptics. You make conversations interesting. I'm still not convinced that the data supports the conclusions. The reason I say this is because the patient self-selected whether to exercise or not, and there might be a bias towards the fact that people who've chosen to exercise are already in a group that are generally okay and at lower risk in the first place. Am I off base?
So I think this is, kind of what we were talking about before. I think it's a super important question. And I think, as we talked about, we really did look both in the design of the study and the different analyses we did, take that into account so that we were not biased by more symptomatic people choosing not to exercise.
Adam, I still love you. I love your questions.
Yeah, super important question.
Super important questions. Okay, I'm going to generalize this question a little bit because it's very specific and we do not do consult by webinar. So can somebody who is over 65, who has had an AFib ablation, myectomy or alcohol ablation, they've had some procedures done, they're probably on meds too, can they safely exercise?
So from the safety perspective, we did have myectomy, people who'd had myectomies in the study. We didn't really have enough to look at them as a subgroup. There was not a signal that they were doing worse with exercise than other individuals. Again, if they're assuming you're able to exercise, there wasn't a signal they were doing worse with exercise, but there weren't really enough to say. I'm going to go ahead and jump into the next question, Lisa, which I'm seeing is about apical HCM, sort of a similar type of question. Apical HCM, we did have more. And so we were able to look at those, look for interactions. Was there any interaction, with having an apical phenotype? And there was not. So it didn't look like things were different for the apical type of HCM.
what if you've had several cardiac arrests? Is the advice the same for exercise and a person who is more prone to arrhythmia?
Rachel, why don't you take that since
Yeah.
yeah.
So someone with several arrests is going to have a defibrillator. It's very important, though, that we're confident that your arrhythmias are reasonably well controlled. If we knew that you were never going to have another arrhythmia, we wouldn't need to give you a defibrillator. And the defibrillators do work, we know from this study and from the prior ICD sports registry. But if you're having a lot of arrhythmias, or like really, if you have an arrhythmia with your defibrillator, it's really important that you work with your doctors on ways to suppress that. So there's medications, sometimes there's procedures that can suppress arrhythmias, but someone who has had, is having sort of ongoing arrhythmias, we really would want to hold off until we get those under control. So it really is a very individual type of decision, kind of between you and your doctor, where things are with the control of your arrhythmias.
Charlene, this one's for you. Are there going to be other exercise studies in HCM at Penn?
Well, I mean, not at Penn specifically, but Penn would be a part of a larger multi-center study that Rachel and I and Mike Ackerman are planning. There is the LiveXT, so I can put a plug in for that if you were in the LiveHCM study, that we would be very interested in continuing to follow you, so we get longer term follow-up. And we're planning, the next phase, so stay tuned.
Yes, if you were in the original trial, you can stay in the extension. And Cheryl would be really excited to hear from you, and we want to make her happy. She's worked so hard on all this.
Very hard. Yes.
Very hard. So she'd love to get more records and love to get more information. So
Absolutely.
please, if you join the first, you can continue on the extension. I know somebody's going to ask me, what if I wasn't in the original study? Can I join the extension study?
Right now, no, but get in touch with us, and at some point, if we are kind of starting to open enrollment, we'll let you know. So do get in touch, and we'll let you know.
That sounds good. Okay, we're going to do rapid fire session now, guys, because Rachel's got a timeline here. Any data on endurance sport, meaning moderate to high intensity for 20 hours a week, a heart rate zone that has been recommended. This is coming from somebody who was an endurance athlete and has been diagnosed somewhat recently with obstructive HCM. So there's a couple of people in this group that I know are here. So it's a specific question, but it's a broader one.
Yeah, I mean, I think we had endurance athletes well represented in LiveHCM. So I think that, that these data are relevant for you. We don't really know if there's an upper threshold by which, the risk might change, but we haven't identified one yet. We also there's no evidence that long-term systematic training is bad for an HCM heart. In other words, that it causes the condition to progress in any way. There are no data to support that. And as far as a heart rate zone, I generally, don't give anyone a heart rate limit, but we can set based on a stress test where your aerobic zone is, where your anaerobic zone is, if you are interested in training in a specific way. But we don't have any heart rate threshold that we typically recommend.
Going a little out of order here because it's the same asker. I think we differentiated moderate versus vigorous exercise quite well. I'm going to say that that's an answered question. However, Lisa, if it's not an answer, ask again and I'll try to get to it. Individuals with ICD do rope courses and zip lines. They've gotten different answers. So rope courses and zip lines, where do they sit in terms of athletics?
Well, so a couple of approaches. In the ICD sports registry, we enrolled individuals who were doing what we would have considered dangerous sports, things like rock climbing, because theoretically there's a concern that if you're in a position where loss of control could be fatal, then, there's a chance that if your defibrillator goes off, you could have a loss of control on something like rock climbing. Those are true hypothetical potential, things that could happen, but they're pretty rare. And I know one of my prior colleagues, Dr. Jacoby, looked at HCM and roller coasters and found that people were doing okay in that situation. So, I think you have to talk to your patient, but say, the chance of having a problem on something like that is pretty low.
Yeah, the paper on thrill-seeking activities had a lot of people going on really big roller coasters and not
Yeah.
having events.
Yeah.
And people were very happy to hear that. So roller
I think
coasters.
I would have an event if I went on a roller coaster, but that's a different story. Lisa, I can take the next three if you want. I can sort of do them
Go right
together.
ahead. Go right
For the interest of time. So if you are thinking of your work, you are doing moderate exercise currently, but contemplating returning to vigorous, how do you bring this up with your cardiologist? Have them read the Live HCM paper. That will provide some reassurance. That's the first thing. The next question is about warm up. And I've had a lot of discussions with Lisa about this. Should we be more careful warming up? I think that my perception from a lot of my patients is that they do better and they feel like they need a longer warm up to just get everything sort of going. You know, I don't know if I have a better scientific or medical term for that, but it just seems like the warm up helps them. And I generally tell people if they're going to be doing high intensity stuff to get a good warm up in. And if they're doing like a high intensity sport, like where they're going out in the field and sprinting and then coming back, you know, basketball or football, that they keep moving on the sidelines so they keep their heart rate up. You know, it's somewhat intuitive and I don't have any real data to support it, but I do feel like there's some, you know, that there's some, you know, that is probably a wise practice. As far as isometric exercises, you know, there's been a lot of recommendations to avoid heavy lifting and isometric exercise. I mean, there's never been any data to support that. And I think strength training is good. I generally advise people to do a higher repetition, lower weight, but there are people that want to do bodybuilding. And then, you know, that's just the shared decision making and individualized, you know, exercise programming.
Okay, so we'll go to a trickier question. Somebody who's looking to get on a transplant list, is moderate weightlifting to build upper body strength a good idea, or is this one that really needs to be discussed with their team about what they can handle at this point?
I think
It's probably, yeah, I mean, I think it's, I mean, I don't know if it's like, are you specifically to get in good shape for the transplant or just, you know, I'm not sure what the focus on upper body strength is motivated by, but I mean, I think that weightlifting and generally, you know, like core body strength and, you know, upper and lower body would be beneficial. So
As somebody who's been through transplant, core is everything because you have to move your body with your core and it's going to be hurting for a while. So building up your core is probably a wise idea, even if you can't do a lot of exercise. Core exercises help me a bit. And I lost all the muscles in my legs, which took me months to get back. Guidance that I was originally given cautioned against activities such as weightlifting, more towards walking and jogging. We've already just touched on that. So Stephen, I think we've answered your question. It can be done. Are there any additional studies about this on the horizon? We just talked about that. So yes, stay tuned. Mavacamten is now an option for some. We didn't have any mavacamten patients, I believe, in this study.
no, because we finished enrolling in 19. I mean, there by the end, there might have been, but there just haven't been that many total, you know, individuals on mavacamten. So
they would have to been in a research study because it wasn't approved then. So I probably not, because if you were in a mavacamten study, you weren't usually permitted to enroll simultaneously in another trial. So
yeah, I think the answer to that is no. I think there was an exclusion for the MAVA trial. So it's an interesting question, and we'll see how MAVA might and myosin inhibitors might impact exercise tolerance in the future.
I mean, from a safety perspective, you'd have to imagine, you know, people are with less obstruction are going to feel better and probably be able to do more. But, you know, we don't have the answers to those questions.
It's kind of looking like it's leaning that way, but the data is still pretty early. We've got about 3,000 in the US taking Camzyos on label, and then you've got the trial participants. So who knows? How does a risk event of 4.7 in your subjects compared to the general population who vigorously exercise?
Well, it's higher. I mean, people with HCM have a higher risk of arrhythmic events than people in the general population. It's just that the relative risk is no different whether you're exercising vigorously or not.
You're welcome, Justin. Are there any weightlifter studies you had a lot of weightlifters in this study.
We
you
haven't
had
looked at them specifically, but you know, at some point in the future, we probably will look at them. I'd like to just real quickly jump in about the person asking about studies for SICDs. There's actually a study just starting for the SICD. So the person that asked that, just get in touch with me and I can tell you how to connect with those people.
Casey, give the office a call. We'll link you up.
Yeah.
So
There's also the ORCA registry, which you
Yeah,
need to
we
be
should talk
eligible
about that one too. Yeah.
Yeah, and that's you can self-enroll. So if you get in touch with Rachel, she'll point you.
Yes, the ORCA is for just at least if we can take two seconds to,
Go right ahead.
to talk about these ongoing studies. So ORCA is a prospective study for college athletes and professional athletes, and the SICD study is for includes recreational and competitive. But you have for those with a subcutaneous ICD. So they're two totally different studies. A rare person might, be appropriate to be in both, but they're two ongoing studies that people can connect with.
Okay. Lee, this is our second meeting today. Glad you're here, but I'm tired. You should be going to sleep. Oh no, it's actually middle of the day in Australia. For patients who have had multiple episodes of VTVF, how can the current guidelines and study findings be applied?
So this is similar to the question the person asked who had multiple cardiac arrests. If you have ongoing arrhythmias, it's really important to be in contact with your doctor about how to get them suppressed. And I think that is a group of people that I would hold off on really pushing yourself until it's okay to walk. Doesn't mean you have to sit on the couch, but I would avoid really pushing yourself if you're having ongoing arrhythmias, and that's a time to work with your doctor.
Okay, so we mentioned risk can change. Can HCM apical aneurysm actually improve for patients, or is it a steady decline? So HCM hearts that are becoming more involved, they don't get better. They just may need to be managed differently. Would that be a reasonable way of phrasing that, doctors?
Yeah, and I don't know that it's not I think not everyone has a steady decline. Many people go on and live their lives and their heart sort of stays the same. And then others that seem to be declining might be ending up on other sorts of medications. But I don't think someone should assume that if once you're diagnosed with HCM that things are going to just always necessarily be a steady decline. And Lisa and Shar, would you agree with that?
Yeah, it's not linear, and it's definitely not
So
predictable.
we are not taking verbal questions. You need to use the Q&A box, and Rachel's going to have to leave in a minute. So I just want to go back.
I can stay on if you need me to stay on for a few minutes.
If you could stay on for a few more minutes, we can clear up these questions, but I want everybody to go back in and take that poll again. And we only have about half of you online who have taken the poll. So please take the poll and let us know if you feel a little bit more, you got some clarity here. And if not, we're going to ask questions later. If you don't, how we can actually make that happen. We know that this is complicated information and it's confusing to some. So our goal is to try to make it clear and understood and make sure that you're comfortable living your life with the heart that you have. Okay. Was there any age breakdown in the analysis that people should be aware of? Was it a certain group at higher or lower risk?
No, we haven't looked specifically at that question, but controlling for age was one of the things we controlled for, and when we looked at the specific subgroup of the young people, the high school and college, where we compared the varsity athletes to the rest, that weren't doing any worse with exercise. So yeah.
So Lisa, the question on evaluating competitive athletes was competitive athletes with HCM, not just all athletes. That would be a really big study, and we don't really know what we'd even look for in that study. But thanks for the suggestion, and I know where to find you.
Yeah, and people asking about other studies, please feel free to email me, it's an easy email to find online.
We will make sure they all have it in the follow-up email that they'll get from us with the link to the YouTube so that they can watch this again and again and come up with 10 more questions to ask, I'm sure. Okay, so we're doing a little bit better. We still have one that's really confused with the difference between exercise, competitive sports, and athletics. Sorry, we didn't clear that question up for you. Okay, a couple more questions, and Rachel, when you have to run away, go with our thanks and appreciation, and we will send you the link. So you
All
can-
right, thanks everyone. And thanks so much I just want to say too, I don't think we've said before, if people listening on the call are participants, thank you so much. It was really so wonderful to have the participation of all of our participants. So
I actually have a slide thanking all the investigators, because there were a lot of them, all the sites for recruiting, and all of the patients for sharing their time and answering questions. Without
absolutely.
you, we can't learn more. So thank
Yeah.
you, thank you, thank you. Thanks to everybody who participated. And a big thanks to Cheryl, who did a lot of the administrative work behind the scenes. So yay, Cheryl, great work. We really appreciate you. We do have a couple more moments to answer some questions with Dr. Day. And I'm going to end the poll and I'm going to show the results. Okay, so sharing the results. So we took the question based on what I've learned today, the information provided during this webinar, I feel clear and comfortable with my understanding of what level of activity might be right for me. Now, you haven't talked to your doctors yet, so we're hoping that you'll go do that and have these in-depth conversations about you, your anatomy, your hopes, your wishes, your dreams, and what activity is appropriate for you. But we did grow on that number up to 58% completely agree. 32% somewhat agree, 8% are neutral, and 1 disagrees. So they're not clearer. Sorry, we tried. We'll get better someday. Based on what I learned from the information in this webinar, I am clear on the difference between exercise, rec sport, and competitive sport. So we have 55% completely agreeing, 34% somewhat agreeing, 8% neutral, and 1 completely confused still. So we moved the mark a bit. We're not perfect yet. Someday we will be. Today's not our day, but it's an evolution, and we hope to make you to understand better as we go forward. That's why we do these webinars. So, okay, let's go back to the questions and wrap them up. How can I find out what my max heart rate is for patients in the study who had defibrillators and doing vigorous exercise? I don't know that we captured that
I don't
data.
think we captured that. Maybe Cheryl can help me, but I don't think that we can retrieve that.
Do we know?
I don't have that offhand.
Okay, can't help you with that one, Casey, but stay tuned. We'll try to get additional
And the other thing is, even if you have a defibrillator, it's not necessarily gonna, because your max heart rate may be below a certain threshold. So depending on how your defibrillator is set, it's unlikely that even if we were capturing it, that we would have that information.
Correct. If you have HCM, when you do a stress test,
Oh,
okay.
blood pressure drops. Yeah, this is
Blood
an
pressure
important
drops.
question. So this is common. So a number of patients with HCM have an abnormal blood pressure response to exercise, which means it either falls by 20 points or it doesn't go up by 20 points. So normally your systolic blood pressure, the top number, should go up by at least 20 millimeters of mercury when you exercise. And if that doesn't happen, or if it drops more, then that's considered abnormal. In the RESET study, we did exclude patients that had an abnormal blood pressure response to exercise, because at the time we were unsure as to whether we were concerned about some safety issues related to that. But I will tell you that there are a number of different reasons why that abnormal blood pressure response happens, and sometimes we can fix it. So sometimes related to medication. So taking too much beta blocker or too much of something else can cause an abnormal blood pressure response to exercise. Sometimes it's just not right. Like sometimes the blood pressures that they get during the test, it's not reproducible. So if you go back for another stress test, it doesn't happen the next time. So I think that generally it's one of those things that you need to work with your expert provider and individual decision making around an exercise program. Now, if you're getting symptomatic when you exercise, you're getting lightheaded and you feel like you're going to pass out, that's a different story than just your blood pressure not rising normally, but you feeling okay. So it just means different things in different patients. So,
and this is why expert review is critically important. So we understand. Okay, I'm sorry, Nadini. I don't know if I'm pronouncing that correct. I'm sorry if I'm not. Any of these studies accept participants less than 18. There were a lot of children in this study.
So that it was ages 8 to 60 in the Live HCM study, and we had a number of pediatric patients in Live HCM. The ORCA study that Rachel mentioned earlier is only adults right now because it's focused on collegiate and professional athletes. But if we do an extension to Live HCM, or well, we are doing extension, but if we start enrolling new patients again, we will definitely include pediatric as well.
Okay, Ernie, you're welcome on the recommendation on the core exercise for pre-transplant. I encourage you to join the transplant pathway discussion group held once a month at the HCMA in a webinar like this. Actually, it's a Zoom room, not a webinar. So join us and we'll help you get through that process. Answered live, done. Okay, we have 3 more questions and then we can let our people go. I have apical HCM, just got an SICD. I do not have an aneurysm. Told no intense basketball. Now I can do things. I love this study. Question mark. Individual analysis, work with your team. If you don't have a team who has knowledge of this data, maybe working with a sports cardiologist with a specialist in HCM might be able to help you as well. We actually have people who do that, and they're pretty cool people who understand both worlds. So if there's anything we can help you with, just give us a call, anonymous, and say, hi, I'm anonymous. No. If you are, let's see, I may have to smooth this one out. Not really a related question, Jennifer, but I will just ask this as a general question to Dr. Day, the HCM doc, not the sports guy person here. Apical myectomies, do they have an impact on arrhythmias?
Not that I'm aware of. I don't think it's been systematically studied though.
I would go with it hasn't been systematically studied. After
Small
seeing,
population.
yeah, it's a small population. So I don't think there's data out there yet, but good question. Chris, have you seen evidence of pathologic athlete's heart as the, okay. Could you please explain the difference between athlete's heart and hypertrophic cardiomyopathy, Dr. Day?
Yeah, so athlete's heart is physiologic hypertrophy that is characterized by mild thickening of the muscle, but also dilation of the cavity. It is distinctly different from hypertrophic cardiomyopathy. However, sometimes it can be difficult to make the distinction. And so that's why, again, just to reiterate, it's important to go to an expert who is able to tell the difference between HCM and an athlete's heart or physiologic hypertrophy. There are some algorithms, there's some specialized testing you can do. Cardiac MRI can be helpful, genetic testing can be helpful in differentiating those that are in the gray zone based on conventional testing, like an echocardiogram, for example. So the question about whether so I think what you're getting at with your question is whether a high level of training can actually cause pathologic hypertrophy. In other words, can you get HCM from training, or can you exacerbate HCM? And there is absolutely no evidence that that's true. I can't say 100% for sure that it couldn't happen, but so far we don't have any evidence that systematic high-level training causes HCM or causes the condition to progress.
There's another piece that, given the topic that we're talking about today, I think makes sense to discuss. If you have athlete's heart, you're typically going to have a concentric form of hypertrophy. The whole heart muscle is going to be thick. This individual is questioning whether his myectomy was needed because of athlete's heart. So we don't tend to see outflow tract obstruction in athlete's heart.
Right, and it's not asymmetric. So if you have a septal myectomy, then you didn't, then it was an athlete's heart, is that, I guess.
Yes, and I think statistically speaking, you're going to have a certain number of endurance athletes that are the 1 in 200 that are going to happen to have hypertrophic cardiomyopathy too.
Right.
So it's true and unrelated. And you were an endurance athlete who had HCM.
Yeah, I have plenty of folks who were, who had myectomies, who were athletes, and then continued on in their sport after their myectomy. Some of them were genotype positive, some were genotype negative. So the two can occur together, but I think in this case it's probably more coincidental than a causal relationship.
Okay, so our last question up here is, Does bigger muscle mean more strain on the heart?
Bigger muscle, I don't know if that's bigger skeletal muscles or
I'm going to go with bigger heart muscle. I'm going to
bigger
define.
heart muscle. Okay. So this is really independent of exercise, I think. So that basically you're saying if the heart is thicker, is it more strain on the heart? I would say in general that is true, but not exclusively. But for hearts that are thicker, there tends to be a higher risk of arrhythmia, a higher risk of developing scarring and obstruction or other complications. But it's not a linear relationship either. Oh, I mean like muscles everywhere else on the arms, legs, and chest.
Thank you for the clarification because I
yeah.
guessed wrong.
Yeah, I actually thought it was that, but I went with Lisa's interpretation.
Okay.
No, no, I don't think that increased skeletal muscle mass increases the strain on the heart.
Okay. Thank you for the clarification, Anonymous. I always say anonymous, like I don't like anonymous. It's fine. I just don't have a name to address you by. And I don't know if it's the same anonymous as we have cleared the questions. Okay. And we're only 12 minutes over, which for us is like being early. So that worked out quite well. We are going to have a session at our upcoming October 21st annual meeting, which is back live in Morristown, New Jersey. And we are going to discuss this with a panel. Actually, we're going to have Charlene, you're going to be on the panel. We're going to have a pediatric cardiologist. We're going to have a sports cardiologist, and we're going to have a moderator. And Marty Marin has agreed to moderate. So I think it's going to be a really interesting, in-depth conversation. We're giving 45 minutes on the annual meeting agenda to this one topic because we know how important it is to get this one right and help people understand how they can feel better, how they can exercise, and really clear it up between pediatric, adult, athletic, not, sports, those in participating. Well, let me say that again, those participating in competitive athletics. So we're going to address all of those issues again in a detailed fashion at the annual meeting. For those of you who are watching on Facebook, we'll drop that link down there later. For those in the webinar room, it's dropped in the chat box, so you can register for the annual meeting now. It's open, but it's kind of like a soft open because we really haven't pushed it too much yet. So we hope to see you all there. Oh, wait, we have one more question. Popping in at the last minute. Oh, and it's Annie. Okay, Annie, just for you, we'll do this one. Right. If you have a patient with documented VT gets an ICD, do you let them play collegiate basketball?
Yes, if they want to, and again, it's a shared decision making, and that shared decision making is going to involve the college and the athletic department and the team and the coaches and so forth. But yes, and the sports ICD registry is very reassuring in this regard because there were a number of athletes, 75 I believe with HCM, Cheryl you can correct me, in the sports ICD registry who were competitive athletes who were continuing to compete with their defibrillator, and there were no incidences of sports-related injuries or shocks, and no deaths.
Would you give any specific counsel to somebody who's going to play at that level? Is hydration, rest,
great question. Yeah, we didn't talk about
planning,
all of that, all of the above. Yeah, that's why it's important. This is not a quick 30-minute visit with your provider, right? This is multiple visits, ongoing discussion with planning, working with your team to make sure that the environment is as safe as possible and they're prepared for any type of emergency, not just for the athlete, but for anyone else as well. So it benefits everybody for them to be prepared for an emergency, including having AEDs, including emergency action plan, and sometimes some adaptations to the training regimen to competition, are warranted. So again, individualized basis.
All right, we're going to say goodbye to the people on Facebook. Goodbye, Facebook. Thanks for joining. And